My official position on this channel is one of statin hesitancy, and the term hesitancy admits to the possibility that there could be cases where statin therapy may be appropriate. Well, we owe it to ourselves to take a look at what those might be. I know this isn't a popular notion with most of my viewers, but we need to develop empathy for those people who have decided that they should be on statin therapy. Stay tuned. So let's get right into it. First, the primary reason that you might decide that statin therapy is appropriate for you is if you find that the statistical benefits of statins are meaningful to you. I mean, this is a valid personal choice. Each person has their own set of values, risk tolerances, and health philosophies. While many in the statin hesitant community, myself included, may prioritize minimizing pharmaceutical interventions unless the benefits are substantial, it's important to recognize that these priorities are not universal. For some, even a small reduction in risk can be meaningful enough to justify the use of statins. And that's okay. I respect that you may weigh the pros and cons differently than I do, and you shouldn't be made to feel that this decision is invalid or wrong simply because it differs from my own perspective. Ultimately, health decisions are deeply personal, and what matters most is that each individual feels informed and confident in their choices. I often get comments from viewers who are clearly taking statins, challenging my value judgments, and I want to assure them that if they have made the choice to take statins, I pass no negative judgment on that. And don't be afraid to reevaluate your decision to take statins. If you've never taken a statin, then adverse effects are really only theoretical. For example, a 30% probability of quality of life altering adverse effects is a chance you may want to take because you feel that the decision is revocable. It's not always revocable because sometimes these adverse effects are permanent, but that is rare, but it can happen. If you take the chance and you find that you're not having those effects, well, that strengthens your decision. But if you do have them, that may suggest that you reevaluate and ask yourself, is it worth it? On a weekly basis, I walk with a group of retired friends, and one of them at least I know is on statins. He had a heart attack 25 years ago and hasn't had one since. He attributes this to the use of statins. Who am I really to disagree with that? Second point is if you trust your doctor and they have thoroughly explained why your specific situation might make statin therapy more beneficial for you than for the broader population, this could be an important factor in your decision. The idea that statins are a broadly applicable medication is one that I object to. They should be a specialty item that is brought out in particular circumstances, and these circumstances certainly do exist. So let's take a look at some of them. The first one I can think of is familial hypercholesterolemia. Now, I have a friend who has familial hypercholesterolemia, which is FH, we'll call it. Some of his not too distant relatives had homozygous FH, meaning that they inherited the genes for FH from both sides of their family, and these relatives had died of heart attacks at very young ages, in some cases under 10 years old. But as it turns out, this friend is also statin intolerant, so he can't take them. He's undergone LDL apheresis, which he told me is even worse than being on statins. He's been on PCSK9 inhibitors, some of which he also couldn't tolerate, and others which were less effective. He's now on bempedoic acid, which so far has worked out for him in both effectiveness and lack of adverse effects. And yes, he has had heart surgery, so this is very real to him. The point is, if you have FH and can tolerate statins, that may be a viable option for you. And if you can't, other options may work. Another case is from Dr. Ford Brewer. He feels that statins can stabilize soft plaque. And in his book that he wrote with Todd Eldridge, Prevention Myths, one of the most important attributes of the statin class of drugs is that they have been shown to attract minerals like calcium and collagen to the wall of the plaque. This is on page 110 of this book if you happen to get it. And he goes on to say calcium and collagen indicate that these lesions have stabilized. It's unstable plaque, which he sees as the major danger, the major risk for a heart attack or a stroke, because the unstable plaque is the plaque that can break off and then lodge either in the brain for a stroke or in the coronary arteries for a heart attack. And he goes on to say, unfortunately, this drug attribute is nearly lost on all but the most discriminating physician and patient. Marketing has effectively labeled these drugs as cholesterol-lowering drugs, and they certainly do that. He does not prescribe them for their cholesterol-lowering properties. He prescribes them for their plaque-stabilizing properties, as he explains here. Another case we may want to consider is postoperative recovery. After a stent is placed, the body may temporarily need support in managing cholesterol and inflammation around the stent site, as excessive plaque buildup or inflammation can interfere with the stent's function. Since the stent is a foreign object, the body's inflammatory response could lead to tissue growth or plaque accumulation. Statins may help reduce the risk through their cholesterol-lowering anti-inflammatory effects during the early weeks of post-procedure. So you see, this is a temporary use of statin therapy. It is not permanent. It's for a few weeks after surgery. The next thing to consider is xanthoma. First, xanthoma are lesions on the skin containing cholesterol and fats. They're often associated with inherited disorders of lipid metabolism, not necessarily FH, but inherited problems with the way the fats are broken down and used. Xanthomas are raised, waxy, appearing frequently yellowish colored skin lesions. I apologize for not providing pictures of xanthomas. You can find them in Google Images, but I warn you, the experience won't be pleasant, and that's why I haven't included them here. Now, while statins can be used to treat the underlying high cholesterol that often contributes to the xanthoma development, they typically do not directly remove existing lesions, meaning that even with statin therapy, visible xanthomas may persist and may require additional treatments like surgical removal or laser therapy to address any cosmetic concerns. And since it's the actual cholesterol lowering that can prevent progression of xanthoma, assuming the cause is actually high cholesterol, other non-statin cholesterol lowering agents such as bempedoic acid or PCSK9 inhibitors may be more appropriate treatments. And then just a warning here, to the untrained eye, exercise-induced vasculitis is sometimes called hiker's rash, and I got it for the first time right after my recent hikes, or sometimes called golfer's rash. They can resemble xanthoma, so getting a proper diagnosis is important. The hiker's rash went away after a week or two, which is pretty normal. It's a self-limiting condition. Then there's the matter of secondary prevention. While I found evidence for a limited risk reduction for very high-risk patients, the data is too thin to really draw a conclusion. I revisited absolute and relative risk reduction. I said at the higher levels, it appears there's really not much benefit from taking statins. The problem is there just aren't that many studies of very high-risk patients because there are ethical concerns. When you have a control group that are dropping like flies, they'll say, oh my goodness, we can't keep this trial going. There's just too many people dying from it. So we really don't have a good base of information for how statins really help in the extremely high-risk cases. My feeling has always been, well, if they're that high risk, maybe statin therapy is not really going to do much. If we look at the absolute risk reductions, then what we find is, again, on very limited data, that the 10% to 30% risk range is where statistically there is the most benefit from statins. And again, in almost all these cases, the benefit, the absolute benefit, is less than 4%. There's a few between 4 and 6%, and there was one outlier where the absolute risk reduction was 8.5%. But in general, we just have to keep those in mind. For secondary prevention, this may certainly be a consideration. So here are some public statements from doctors who I consider statin hesitant. As far as I know, they don't use that term, but I think they might agree if I were to explain what I mean by it, just based on their general statements. First, as I mentioned before, Dr. Ford Brewer, when recommending low-dose statin, he says, I recommend statins only if you already have plaque. And he also used the phrase higher than normal. I haven't had an opportunity to ask him what constitutes higher than normal. And he goes on to say you don't have to watch LDL, you have to watch cardiovascular inflammation. And this is in a YouTube video of his. You can find the cross-references in the description for all of these. Next, Dr. Rob Cywes, the carb addiction doctor, and he says if your blood work shows that you have low HDL and high trig count, irrespective of your LDL count, and you're insulin resistant, that is the only place where there's an absolute benefit from being on statins. Well, that's interesting because there's this case where saying you're insulin resistant, and of course statins may make you worse on insulin resistance. I think if I were to provide context to this, this probably was a statement he made in the context of somebody has tried lifestyle changes and they just haven't worked. Dr. Asim Mohatra, who is probably one of the most outspoken critics of the overprescription of statins, he says it right here. This is about the overprescription of a drug which helps a small minority of people, in particular those with established heart disease. So he does acknowledge statin use for people with established heart disease. And again, that was in an interview with the YouTube channel Pro Longevity, and you can watch him in that interview. I mentioned Dr. Kinberry and Dr. Sunil Dand here. I couldn't find any statements. After a brief search, I just couldn't find any statements from them, public statements statements where they might recommend statins. I wanted to mention them because they're both very popular, especially with my viewers. I just want to indicate, yeah, there are some doctors who maybe don't recognize any use of statins. I can't swear that's the case for them. I would have to ask them personally. I just couldn't find any public statements of theirs that would suggest a use for statins. Next, Dr. Anthony J., and he's the one who talked about the postoperative condition. He says, if you have a stent put in a blocked artery, I can see an argument for a couple weeks of taking a statin and a blood thinner. And again, this was from not his YouTube channel, but an interview with A Low Carb Life. Dr. Beatrice Goulom, who is a researcher who is very outspoken critic of statins, she acknowledges men under the age of 70 or 75 who have heart disease on average receive benefit or life extension. And again, that was in a KPBS interview, which you can find on YouTube. Dr. John Abramson, co-writing with Dr. Robert Kaplan, we agree that evidence supports the use of statins for secondary prevention in people with established risk factors or with evidence of atherosclerosis. That was in a MedPage Today editorial, which I reviewed in more detail in a previous video. And then finally, Dr. Rita Redberg, who is also a researcher in this area, says in that population, and she was speaking of the population with prior cardiovascular events, there is good clinical trial data to show that there is a reduction in the risk of a second heart attack and a small mortality benefit. That's the case of the gentleman that I walk with once a week who is on statins and has been heart attack free for 25 years. And that quote was from a YouTube interview, again, with the Healthy Skeptic MD YouTube channel. She goes on to acknowledge that that is a evidence-based use of statins. So for my closing thoughts, I think the important point is that the position of statin hesitancy is not absolute, nor is it denial. It's simply an acknowledgement that the purported benefits of statins as LDL-lowering drugs to reduce cardiovascular risk are less than we would be led to believe by pro-statin statements. Statin advocates seem to lock onto statistically significant results without recognizing that for many patients and doctors, these results are not clinically significant and adverse effects can be substantial. The real denial is from the statin advocacy side that continues to tell us that these minimal, though real, benefits should impress us all. Statin hesitant doctors and researchers generally acknowledge legitimate uses of statins. Now, if only statin advocates would return the courtesy and acknowledge that patients may intelligently view the benefits as unimpressive and may legitimately refuse statins, even as we recognize, as I said at the start, that others may choose differently. So that's what I've got on this topic. If you appreciate this content, please like, share, subscribe, and comment on this topics or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for watching.